Good morning, everyone. Thanks so much for joining us today. We have a short program for you, and then we'd love to hear how you've been doing during this pandemic and also answer any questions that you might have. I'm going to be keeping this meeting at the 1 hour time limit, and that's really out of respect for everyone's time. But I encourage you to reach out with questions today. And if we run out of time, please feel free to ask other questions via email or whatever. You can give us a call. We'd really love to be able to talk to you about whatever topic you're interested in. But out of necessity, we'll be keeping this information at kind of a 30,000 foot level, but any of us are happy to discuss more with you at another time. So this morning, what we have for you is Dr. Brumstead is going to give a brief overview of the work that's been done at the network level. And then one of our staff people, Jen Leckweir, who's a physical therapist, is going to talk about her experience as a home health and hospice frontline staff person. I'm going to give you some information about the financial impact from COVID, and then Todd Peterson, who's the director of our home health services, will tell you about some of the ways that we've changed our practices and innovated to be able to provide care for our patients during this time. Lastly, our VP of Clinical Services, Gretchen Bates, will share some stories with you about hospice services and how hospice had to change and really assist our community during this pandemic. We'll then respond to questions that were sent into today's meeting, but we also invite you to send in questions in real time today. You can use the Q&A option at the bottom of your Zoom window. If you move your cursor to the bottom, you should be able to see it. And we'll do our best to answer whatever questions you have. But if you would like to ask your question over video, or you want to make a live comment during the event, you can go to the More option. It should be 3 little dots down at the bottom of your Zoom window, and select Raise Hand option, and then we'll call on you. So let me just start off by telling you what a absolutely dedicated, professional, caring, and just truly amazing staff that you have here at Home Health and Hospice. Their work has just been phenomenal. Starting in mid-March, we transitioned the work of almost our entire staff to their homes. Our visiting staff, of course, are used to being mobile and starting from home and doing a lot of work telephonically. But we also transitioned, pardon me, our entire finance department, intake and referral, coding and auditing, scheduling, all of our administrative functions to their home. I've worked from my home, welcome to my home, since March 16th. So the threat of COVID was very, very real, as it still is today. And everyone was motivated to solve problems with virtual solutions to try to reduce the in-person contact. And what paper processes still remained were ended. Our visiting staff were challenged with prioritizing patients for in-person visits. They had to wear full personal protective equipment and what we call PPE. And they needed to educate patients about how to protect themselves, and also about how to use things like Zoom and be able to do virtual visits. We actually purchased iPads to help some of our staff, some of our patients be able to do that. Jen and Todd are both going to give you more information about that in just a few minutes. So our home visiting staff, of course, were also concerned about their own personal safety and that of their families. So we did everything possible to assure our staff had sufficient quantities of the appropriate PPE and also up-to-the-minute information on how to manage care. We did daily voicemails and daily newsletters for all of our staff. Home health leaders literally worked 7 days a week, 12 to 14 hours a day to do all the planning, the organizing, and the communicating that was necessary to try to stay one step ahead of this pandemic. I honestly don't have words to express how grateful I am to those leaders and to our entire home health and hospice staff. People really rose to the challenge, and as I said, they've just been amazing. You know, a man named Bob Proctor said that having a sense of urgency is really about getting a lot done in a short period but doing it in a calm and confident manner. And that is exactly what your home health and hospice team has done. So now I'd like to introduce someone who you all know as the leader of our health network, and that's Dr. John Brumstead. And John has shown that exact kind of calm, confidence, support for leadership, and has really just led our success over these past several months. And he's going to share a few words with you now. John?
Thank you very much, Judy, and thank you, everybody, and welcome. I'd like to just start by reminding everybody who we are as the UVM Health Network. We're 3 hospitals in northern New York, Central Vermont Medical Center, Porter Medical Center, and the UVM Medical Center in Vermont. 1 medical group that serves all of our region, and of course home health and hospice, which is our foray into the important area of home health and post-acute care. The COVID crisis really has galvanized for us how important it is to be a family of providers and not trying to go it alone when times are this tough. And being together, we've been much more able to respond and continue to provide access to necessary services for everybody in our region. The COVID crisis really brought forward some incredible examples of how, when like-minded folks come together and bring the resources of their organizations together, as Judy said, you really can move mountains. Early on in the crisis, I asked Al Gobey, our Chief Operating Officer, and Dr. Howard Shapiro, our Chief Population Health and Quality Officer, to coordinate the activities of all of our home health or all of our UVM Health Network organizations. And they did a spectacular job. 4 o'clock every afternoon, 7 days a week. There were leadership participants from around our network, and those calls were so valuable to coordinate our efforts that organizations that aren't even part of the UVM Health Network but serve communities in our region joined on. Some of the things that we did as a network that were very beneficial, we all came together as one large supply chain and actually partnered with the state of Vermont and with Dartmouth-Hitchcock Health to be able to have enough scale to actually get the vendors to answer our phone calls when we were seeking to replenish our supplies of PPE or needed pharmaceuticals. That was a huge effort, and we very quickly decided to stock all of our organizations centrally, again, so that nobody ran out of particular drugs or pieces of professional protective equipment, that we could make sure that we balanced our supplies, which were pretty scarce at the beginning, with the needs of everybody in our network. We also came together as a network when we stopped providing non-essential services with a visitation policy and a policy on the use of PPE, particularly masking, so that, again, we could have a consistent approach across our whole network, which was very, very helpful to quell some of the anxieties that our staff and our providers had. And of course, throughout all of this, home health and hospice, really, as Judy said, the staff and everybody were wonderful. They really stepped up, helping to treat COVID patients in the home so that they wouldn't have to come to the hospital, really stepping up to help us work with patients that were COVID positive that were in nursing homes. It really was a tremendous effort. Just a couple of comments on the financial impacts. Just like all other aspects of our national economy, healthcare has really been hammered by the COVID crisis, not only providing the services for people that are critically ill, but also stopping our non-essential procedures and interactions with patients. And the financial impacts on us at the UVM Health Network have been devastating. We've done a lot of work to reduce non-people related expenses, consultants, supplies, things like that. At the same time, early on, leadership agreed to take reductions in salary and reduced benefits. And that's flown over to our direct providers. Our physicians also have agreed for the rest of this fiscal year to reduce some of their compensation. Even with all of that and dollars coming in from the federal government, it looks like as a network, we will lose about $30 to $40 million by September 30, which is our fiscal year. When we originally, in March, were doing the modeling, we felt that we could lose upwards of 200 million. So it's a shallow victory, but a victory nonetheless that, you know, we're going to end the year just at that level. And we look forward to 21 improving our financial situation. Looking forward, which really is my job, we're have great people focusing on all of the aspects of delivering care, our operations, and our finances in the moment. I'm really focused on looking forward, and we all have been impacted, like everybody, with the George Floyd situation and really the systemic racism and bias that is infused in our country. And as a health network, we are very, very focused as a leadership team and throughout our network to move forward and pay very close attention to all aspects of diversity, equity, and inclusion. And we've launched 4 initiatives to start with. One, leadership training. And we've already begun that with our Network Leadership Council. Listening to our people, not talking, just providing the opportunity to listen to our employees and to listen to others in our community. In early August, we'll be throughout the network having an employee survey on issues of diversity, equity, and inclusion. So we'll get some real information. And in the same time frame, we'll be setting up a hotline for employees to report if they've been the victim of bias or racism. So we're very focused on that as a leadership team. And when we get to Q&A, I know Judy or I would be happy to answer any questions in that. 2 other quick things. Judy mentioned the working from home and the corollary to that is doing a lot of patient interaction through telehealth. We're very actively engaged in continuing to make sure that people can work from home if it's appropriate and comfortable for them, not just through the rest of the COVID crisis, but even when we come out of this, the other side of this public health emergency. And the last thing that I'll bring up network-wide for our physicians and our hospitals and our other providers, we are implementing a single electronic health record, Epic. And so that's really one of the only ongoing capital investments that we've continued through this financial difficulty. Incredibly important so that we can serve all of our communities. And we are soon to engage with Judy and the leadership team at Home Health to really think through if Epic is the right move for Home Health, if there's another option, if it is Epic, the pace at which we move forward. So that's more information that'll be coming your way down the road. I'll stop there. Thanks for the opportunity to participate, Judy. And when we get to questions, I'd be happy to answer questions that come my way.
So thanks so much, John. I really appreciate you joining us today and giving that overview. And I'd like to just reinforce everything John said about our commitment to combat racism. We started flying the Black Lives Matter flag at our Prune Road office on Juneteenth, and we're now have a diversity, equity, and inclusion committee that we've set up, among the other initiatives that John talked about. So you'll all hear more about this in our future communications. We have an e-news coming out this week that will explain more about that. So now I'd like to change gears, and I'd like to invite Jen Lequier, who's one of our field staff. She's a physical therapist, and I'd like to ask Jen to talk about some of her experience doing home visits. Jen?
Good morning, everyone. As Judy said, I'm Jen Lequier. I'm a physical therapist with adult home care. I've been with the agency for 21 years, and I'm one of the physical therapists who's on the team of clinicians that works with COVID-19 positive clients. When COVID-19 hit our area, there was a lot of changes to how we as clinicians did our job every day. Initially, we were limiting our in-home visits to essential visits to limit risk to our clients, and started doing telehealth visits either by video or over the phone for our active clients. So it was definitely a shift for me and something that I as a clinician had not done before in home health. It was a learning curve for both myself and patients. However, I found that I was able to quickly adapt to the use of this technology, and if the client was appropriate for this type of visit, they did well either on their own or with the support from family or caregivers that were in the home. I'm pretty excited we have this type of technology available for a visit, and now being very comfortable using it, I know in the future we have that ability, and outside of COVID, this may be a good option for a client in the future to supplement home visits. Once we started seeing COVID positive clients in the home and began slowly returning to in-home visits for all of our clients, there were several ways that my workday would change. The main change and adjustment I felt I had to make was the wearing of personal protective equipment, or PPE, for visits. At a minimum, we are wearing masks, gloves, and a face shield for all visits. And for clients who are COVID positive, we are wearing an N95 mask, gown, gloves, and a face shield or goggles. Wearing of the PPE initially felt pretty difficult. It felt like a little bit of a barrier between myself and my clients, but having worn the PPE over the past several months, I feel that it has gotten much easier and has become part of my normal day in the field. I no longer feel like it's a barrier. And there are some days where and some visits where I actually forget that I'm wearing a mask and a face shield. The main focus with us wearing the PPE is that it's something that we need to do for the safety of our clients and their families, as well as for ourselves. It's now the regular part of our job. And as I learned quickly in home care, you need to adapt to the changes that come in the surroundings we're in, as no day is really ever the same. That is also what makes me working in home care a great place to be, and it's the reason I continue to work in the home care field. Other aspects of my job that have changed were around how I set up and run my day. It was no longer as easy as calling a client, setting up a time for a visit, getting out of my car with my bag and my laptop, and going into the home and doing a visit, and then on to the next. We've had to adapt to a new way of doing things. Initially, the amount of new information coming to us about COVID-19 and changes that needed to be made to do our jobs every day was extensive and was changing daily. We had daily updates coming to us that we needed to stay on top of and adapt from one day to the next for any changes that were made. We continue to receive a biweekly newsletter with any updates or new information that we need to follow. We screen clients prior to our visit or at the start of each visit, as well as anyone who is present in the home during our visits for COVID-19 symptoms. If a client or family member screens positive, then we have a course of action that we follow, and this may also mean addition of PPE as well as additional follow-up. Our initial conversation with a new client on the phone for me before would be a quick check-in, setting up a visit time and confirming an address. Now with our initial call to our clients, we may gather a bit more information on the phone rather than do this in the home. When actively seeing COVID positive clients, the setup of my day will look different. I may try to see all of these clients on the same day or at the end of the day. The preparation time just prior to going into a visit and at the end of the visit to be ready for the next has changed and has increased. I need to make sure that I have the correct PPE on for each visit, decide what I'm taking into a visit with me, and after a visit, making sure that everything is sanitized correctly for the safety of our clients. This can change depending on my day and who I'm seeing. I've had to look at how my car is set up. This is basically my real office, and make some changes to my regular setup to maintain the safety for my clients and for myself. If I'm actively seeing a COVID positive client, then my return home from work also looks a bit different than it did before. I've made changes to my routine to keep my family safe. I cannot just walk into my home and give my family a hug and a kiss. As much as I've adapted to all of the changes, so have our clients. I've found that my clients have really not been fazed too much by the amount of PPE that we are wearing in the home. Many of our clients have discharged home from the hospital or rehab setting and have already been exposed to clinicians wearing PPE before we have seen them. For other clients who have not been in this type of setting, the amount of information they have received prior to us coming into the home, I feel, has prepared them. I make sure that when I have initial contact over the phone with a new client, that I make them aware what I will be wearing when I come into the home so that they are prepared, and this has been helpful for them. I feel overall my clients have really adapted well to all the changes over the past several months and continue to express how appreciative they are for the steps we are taking to keep them safe when we see them for services. I feel that our role in the community is vital, and I'm happy to be able to go out into the community every day and take care of our clients to keep them functioning and safe in their homes. I hope this has given you a small glimpse into our day as a clinician. Thank you.
Thank you very much, Jen. I really appreciate you giving us that kind of inside view of what your day is like. I'd like to say a few words about the financial impact that this pandemic has had on home health and hospice. As you might imagine, it was imperative that we immediately cease the operation of any programs that were held in a congregate setting. So that included our 3 adult day programs, SASH services, foot clinics, pardon me, and even our bereavement groups, which we did eventually transition to virtual meetings, and that has worked well and been greatly appreciated. We also needed to curtail as many of our in-person home visits as possible and set them up as Zoom meetings, just like you and I are doing today. And while this enabled us to continue the important services that patients and families rely upon, unfortunately, Medicare will not reimburse a home health agency for virtual visits. So we were providing a lot of care through Zoom, and paying our staff to be able to do that work, but had no revenue for those visits. And even though we were reducing many services, we still needed and wanted to support our very dedicated staff. So, pardon me, I have allergies, and so it just leaves me with this hoarseness, so I'm always clearing my throat, so I apologize for that. As I said, we wanted to support our staff, so we kept almost everyone on payroll until they were able to receive unemployment benefits. Staff really appreciated that, but of course that has now increased our out-of-pocket payments for unemployment benefits. And of course, many patients still did need to receive in-person visits. Examples would be people who needed wound care, IV infusions, physical assessments, and other hands-on treatments. It's been paramount that we provide our staff with the appropriate and high-quality PPE that you heard Jen talking about. And this has, as expected, come at a significant expense to the organization. All of this has resulted in lost revenues and increased expenses of over $1.5 million, probably closer to $2 million during the first 3 months of COVID. We're still, calculating all the additional expenses and lost revenues. So this is in the last 3 months of the COVID-19 outbreak in Chittenden County. So I am very happy to report that we have received corona relief funds from the federal government and also some other monies as a pass-through for corona relief from the Vermont legislature. And that this has helped offset some of this negative financial impact. We were grateful to be the recipients of an estate gift in May of $125,000, and also several very generous gifts from donors like yourselves. All of this has just been a tremendous help, and these funds have been used to purchase the PPE, new iPads to be able to have more patients able to do virtual visits, monitor fees for the telehealth monitors we have, and payroll for our staff, of course. Going forward, we'll continue to have increased expenses for the PPE and IT tools that we use for virtual visits, as well as other supplies and equipment, all related to this new normal that we're now practicing in to provide care to our community. Those of you on this call have been our loyal supporters over many years, and I just cannot thank you enough for also supporting us during these unprecedented times. We need it and we appreciate it. So, again, thanks so much. Now what I'd like to do is introduce Todd Peterson, who's our Director of Home Health Services. Todd will share some of the innovative strategies that we've been utilizing to care for our patients during the COVID pandemic, right? Okay, thanks to you, Todd.
Good morning. I'm going to tell you a little bit about our telehealth use during the pandemic. There were two main areas that we addressed. One is through remote patient monitoring, and we have a platform some of you may be familiar with called Vivify. It's a tablet and vital sign monitoring equipment that goes into the home. The clients are trained to be able to take their vital signs, and they submit those daily to a telemonitoring nurse, who then monitors them for variations and contacts the client or the physician as necessary. Those tablets also allow us to push out education in the form of quizzes or videos, and they also allow us to request a video visit. And so we can video visit with those clients and check in on them and get eyes on them. So the wonderful thing about that equipment is it allows us daily monitoring of our clients that would be really difficult to do in person. As you can imagine, through the pandemic, that use has gone through the roof. And what we normally had as a reserve to allow us to turn around those units and clean them is now out in the field. And so we are looking at the need to expand that to support these people and keep them home safely. And what we know statistically is these people do better at home and don't need to go to the ER as frequently because of this continued monitoring. The other way that we use telehealth during this, and Jen and Judy have both mentioned it, was to use Zoom for televideo visits in the home. We had done a brief pilot with our pediatric rehab program because the state had allowed that use to be reimbursed. And so we had some idea of what we were getting into. But within about 2.5 weeks, we had the entire agency virtual, doing telehealth visits from home. Each clinician had their own Zoom unit, their own access, and they were using that. We did find, however, that some of our clients weren't able to access the technology, either through the lack of smartphones or tablets or computers in the home, or reluctance to do that. And so we also had to use telephone calls. So we did a lot of telephone calls. In fact, I just got the numbers this morning. We actually performed 5,479 visits through telehealth in the last 3 months. So we did a great deal of work in a very short time. So I'm really, really proud of the work that went into that. We did obtain additional iPads. We used those with our clients. We also put them in assisted living and subacute nursing facilities in the community that we partner with, so that we would have a sure, reliable way to communicate with the clients in those buildings. We still continue to use the video visits when it's clinically appropriate. Our speech language pathologists, our social workers have really leaned into the technology, and they continue to use that. Our training came from IT. Our IT department helped roll out the Zoom training. Our education department provided some tips and guidelines. And then a lot of our professional associations for the clinicians also had videos and education available to them. I think probably the best learning, though, is always the peer group, so the physical therapists sharing tips with each other, occupational therapists, and so on. Looking to the future, we'll continue to use this where it's clinically appropriate. We are looking at using it for staff training too, to allow, for example, our wound ostomy continence nurses to do a collaborative visit with a field nurse and be able to see the techniques and guide them through their treatment plans. As Judy mentioned, one of the biggest challenges to us was really accounting toward our work in our Medicare episodes. The state does recognize the video visits, and we were and are being reimbursed for the state programs. But with Medicare, it's actually a challenge because it's a potential loss because we didn't do the visits that were expected. I guess the other thing that I would share is that, relative to the safety, we continue to do a daily COVID positive tracking that comes from the medical center so that we know who's coming to us or who's already on caseload that is COVID positive. The clinicians do a self-check every day just to make sure that they don't have any symptoms. And then they do a pre-screen for all of their clients before they go to visit too. So we continue to do all those screenings to make sure that we're being thoughtful. And then we also record that in our electronic medical record for other clinicians to review as well. So that's my update about telehealth.
Thanks very much, Todd. Appreciate that. And now I'd like to ask Gretchen Bates, who's our VP of Clinical Services, to talk to you a little bit about hospice. Gretchen?
Hi, thank you. Thank you, Judy. Hospice care is a large portion of our organization's work, and I think that we oftentimes associate hospice care with the McClure-Miller Respite House. But in reality, we do a significant portion of hospice care in people's homes and skilled nursing facilities with our community hospice team. Since the start of the pandemic, we've seen an increase in the average number of clients in our community hospice team by approximately 20 to 30 clients. And most of these clients are being served in their homes rather than in skilled nursing facilities or assisted living facilities. In fact, in the beginning of the pandemic, most of the skilled nursing facilities stopped allowing our hospice teams, such as nurses, chaplains, and bereavement and social workers, to enter the building in an effort to really keep their clients safe. When that occurred, we recognized the need to continue to provide hospice care for these patients. So we rose to the challenge by including new and more telehealth equipment to the skilled nursing facilities, allowing us to do telehealth visits with clients. This was a new model for our hospice team. And while some care was extremely successful in this manner, it is not a replacement for a face-to-face visit. And so today we are seeing the reopening of many of the skilled nursing facilities and assisted living facilities, which are allowing our clinicians and our staff to come in and provide that face-to-face care, which we're grateful to be a part of. One of the increases to the hospice census in the community team, we believe, is also related to the way we are now delivering palliative care, and it's a change in our delivery care model. The beginning of the pandemic, our team really felt that there were many clients who needed to have an opportunity to have a conversation about how they would be affected should they acquire COVID. We reached out to many of the clients who had debilitating and chronic illnesses and invited them to have a conversation with our palliative social workers, our hospice nurses, and our hospice medical directors to discuss their goals of care should they acquire COVID. Our team learned that our clients were wanting these conversations. We reached out to 119 clients and had 106 goals of care conversations between March and June. The support that the team was able to give these clients really was about aligning their goals and honoring their wishes for their care. This also greatly aligned with the work that our palliative partners at the University of Vermont Medical Center were doing with goals of care conversations with communities. For this same period, we also continued to receive new palliative referrals. Palliative referrals today look a little bit different than they did prior to COVID, in that if they have a skilled need, they go into the adult home care environment and are cared for by those skilled clinicians with support from our palliative team through goals of care conversations and symptom management. The other area that a referral may go to is to the hospice team if they recognize that the client's goals of care are really consistent with hospice and the client elects hospice care. We've received 21 new referrals between March and June to the palliative team, and all have received goals of care conversation. 12 of them have transitioned to hospice, and 9 have received support in clarifying their advanced directives and putting their advanced directives on file. So we know that we're moving in the right direction for our community as they embrace this new care delivery that we're offering with palliative care. Our hospice team members were also asked to participate with the University of Vermont palliative care team in supporting Birchwood Rehabilitation and Healthcare Facility during the pandemic when there was an outbreak within their facility of many of their residents. We had a chaplain, a hospice nurse, as well as our bereavement coordinator provided care, skill, training, and over many, many weeks helped to support the clients and the staff of Birchwood. Many of our team members worked tirelessly, weeks without days off, because they recognized the need and the opportunity to really help elevate the care within that facility, which was struggling to understand their environment at the time. We were honored recently to be able to participate in an emotional closing ceremony which recognized the residents who had passed during COVID and acknowledged the staff for the tremendous work that they did and stepped up to during the pandemic. At this point, we continue to partner with Birchwood, and we continue to provide bereavement support to their staff through our bereavement care coordinator at this moment. And lastly, we can't talk about hospice without talking about the McClure-Miller Respite House. I'm proud to be able to tell you that the McClure-Miller Respite House staff stepped right up to the challenge when the pandemic began, really put into place some excellent policies to ensure if we had a COVID positive client, how we would keep the rest of the house safe and not transmit the disease further. Many workflows were changed, rooms were sectioned off and remained open in case we had a client who needed end-of-life support at the respite house and was COVID positive. But we at this time have not had one COVID positive patient being served at the respite house. We took our visitation policy and really very carefully looked at how do we keep clients and how do we keep our volunteers, which support the respite house, safe at this time during the pandemic. Our visitation policy slowly, as the pandemic surged, we slowly reduced the number of visitors that were allowed to be at the respite house, but we never stopped visitors. We were always able to, we felt, provide in a very safe manner some visitation, at least if nothing else, one family member to a client within our respite house. We also transitioned out volunteers from much of the work that they do at the respite house in an effort to keep them safe. As we've come through a large majority of the surge at this point, we are slowly reintroducing more visitors into the respite house and reintroducing volunteers back into the work, and we're grateful for their support. We will continue to really keep an eye on the pandemic and make the right choices to help ensure that we have safety within the McClure Respite House. And those are the big changes that we've seen within hospice and palliative care at this time. Thank you.
Thank you, Gretchen. Thanks to Gretchen and thanks to everyone else who has presented today. I really appreciate their help to bring this information to all of you who are our attendees. So now I would like to, it is 10:40, so we have 20 minutes that we can use to answer questions. We did receive a couple of questions ahead of time, and we've had one live question, so we want to get to all of that, but we would invite you, others of you to ask other questions. Remember that you can use the Q&A button that is at the bottom of your Zoom window if you want to type a question. And if you'd like to use, to make a live comment or ask a question, you can use the More option at the bottom of the Zoom window and select Raise Your Hand. So I'll start with one of the questions that came in prior to our event, and that was, does Medicare pay for telemonitoring for healthcare? And so I think we've answered that in our presentations, that unfortunately, no. Vermont Medicaid has, but Medicare, which is really the bulk of our visits, did not pay for the virtual visits that we did. And as I said, that really has had a financial impact on the organization, but we knew that we needed to do the right thing and do care, provide care in the safest way possible. Another question was, how many staff members have been furloughed during this time? And so I'll answer that one also, that we have 80 staff on furlough right now. 40 that are partially furloughed and another 40 that are full-time furloughed. We're bringing all those folks back as quickly as we can. You heard me say that our adult day centers are closed at this point. So those staff, many we have tried to redeploy in other areas of the organization. When Gretchen said that we needed to stop using volunteers at the respite house, we still needed the work done that our volunteers provide such a great service to us. So we use redeployed staff to work at the respite house to serve some of those functions, things like answering some call bells, delivering meals, folding laundry, a lot of the wonderful things that volunteers do for us. Before I go on to some other questions, let me go to a live question that came in for us. And that was, the question was, COVID-19 has brought light on the stark racial disparities with regards to cases and deaths experienced by Black, Indigenous people of color. How is Home Health and Hospice and the network dealing with this reality? And thank you, Hal, for that question. I think we've addressed that somewhat, that John and I both talked about some of the things that we are doing to try to educate ourselves, our boards, and our staff more about racial inequities and making sure that we're not people who just say we're not racist, but that we are people who are anti-racist. We really recognize this disparity in the COVID virus and really hitting those populations harder. We understand that a lot of that is related to social and economic differences. I want to assure everyone that Home Health and the entire network does not discriminate in admission or our care provision, that we make sure that we serve all comers, care for people of diverse backgrounds, race and ethnicities. One of the things Home Health has done, because we do provide care for a lot of people who, sometimes we're called new Americans, but a very diverse population in our county. And we've done extensive education for non-English speaking people, using materials in their own language. So that's one of the ways that we've been trying to help. We also have tried hard to recruit people of color to work with us. And we've had very supportive staff members who have done ads for us and been featured on some of our television ads themselves as a person of color, to be able to get that message across very clearly that we want to employ more people. And then I have personally been doing a listening tour. I reached out to our employees who are people of color and invited them to sit down with me and just tell me about their experience working for home health and hospice, and also living in our community and serving our patients. I've had 3 meetings so far that have just been, very, very enlightening for me and very encouraging, and really have appreciated that. And I hope to be able to talk to more staff. And I know this is happening on a network-wide level also. I'll move on. Our next question is from Charles Bunting. Hi there. It says, Judy, if we can look beyond the pandemic, what impact is it likely to have on the future of home health? So I think, why don't I, instead of me continuing to talk, and of course that's a topic I could talk for the next 30 minutes on, but Gretchen, would you like to respond to some of that?
Certainly. I think we are reimagining what our work could look like, and understanding that there's other ways to deliver excellent quality care to our clients in their home than what we probably traditionally think of as home health services. We are learning that there are some clients who thrive with continued visits through telehealth, telemonitoring. We're learning that there are some services that are better delivered through conversations than through seeing clients and providing a skill. So I think we are learning as we go. I would expect that the future of home health looks more like an organization that embraces technology and IT technology more than it had in the past. What we're hopeful for is that we see new legislation that helps to support these modalities. But I think that you'll see a more technically savvy clinician, yet still able to provide the quality and personalized care that home health is known for.
Thank you for that, Gretchen. And, I would add that I think the healthcare system nationally is recognizing the importance of supporting people in the home at the very basic levels of long-term care support that people perhaps shouldn't be are not as healthy or as safe when in congregate settings, but also at the higher skill level, that there are some procedures and treatments that take place in the hospital or in outpatient settings that could be delivered in the home. So I think we're going to see a lot of change coming up. We do have a live question. Kay Ryder is in the queue. She raised her hand. Thanks very much, Kay. So please tell us your question.
You mentioned that you had gifts from people, special gifts, and you also mentioned that the state of Vermont has given you some money for the telemonitoring. I would like to know right now, can you anticipate at all what is going to happen to the financial situation of the agency during the next year?
So we know that this will not be a fast recovery. We will have significant operating losses. Our fiscal year ends September 30th. We've had a goal to try to mitigate losses as much as possible by bringing in revenue from the sources that you've mentioned, our donors, the COVID relief funds, state and federal, but also what we call reentry, which is getting our services up and running again. And that's all going well. But we know this is going to be, and when I'm talking about home health, but John can address this also, network-wide, this is going to take us, probably more like 18 to 24 months to really recover. John, I don't know if you'd like to say anything more about that.
Thanks, Judy. Just that early on in the crisis, when it became obvious really how financially devastating this was going to be, we sort of laid this out in stages. The first stage was September 30. That's our fiscal year. Let's do everything we can, implementing actions, expense reduction, garnering support, mostly from the federal government to this point, to try and end fiscal 2020 in the best shape possible. And that's what I said, with a huge Herculean effort by all involved. We really have gotten to a place where we don't think that we'll be in violation of any bond covenants or covenants from banks that have loaned us money, and that will probably end this year about $30 to $40 million to the negative. What that does is, believe it or not, that degree of improvement sets us up for fiscal 21, the budget that we're putting together right now, to get back in the black as a network, as a family of organizations, and really for fiscal 22 to get back to the level of financial health that will allow our organizations, like all not-for-profits, to have enough resource to invest in people and programs and capital. So we've really laid this out as a 30-month recovery from the start, and we're not trying to get there all in one fell swoop.
Yeah, thank you, John. I appreciate that. Kay, did you have a follow-up question, or shall we move on?
Move on, move on.
Thanks. Chuck has asked a follow-up question about telemonitoring and asks, is there any effort to change the Medicare policies to telehealth? That will be necessary to achieve the future that Judy and Gretchen were just talking about. And yes, there is, Chuck. We're working through our state association, which is working with our national association, and then of course with our individual senators, congressmen. So there is an effort. It's really hard to determine what the success of that will be. But we certainly are making that push and trying to have Medicare understand not just that, that we want to be paid for this, but the benefit that it provides to people, and that it may actually, in the long run, save Medicare money. If we're able to provide more telehealth services at home, we may be able to prevent hospitalizations or acute exacerbations of certain disease processes. Our longitudinal care program is a great example of this. It's really, we serve people in their homes, even if they don't have a skilled need. We use telemonitors, and that program has just had fantastic outcomes of being able to reduce healthcare utilization and keep people healthier. So we have another question. Barbara has asked, says, thank you so much for being the organization that we in our communities can count on to be there in a time of unprecedented crisis. You make us proud every day. Thank you so much, Barbara. Barbara is a past board chair at Home Health and Hospice. She knows our work well, and Barbara, thank you for that vote of support and confidence. And Raquel says, thanks so much for all these updates. Sorry if I missed this, but can you speak to the status of your adult day program and the possible future of those services? So Gretchen, why don't I pass that to you also?
Sure. We continue right now to be working very closely with the regulating bodies within the state of Vermont to create guidance as we move forward to how could we open the adult day programs across the state of Vermont in a manner that would be safe and supportive and still provide the services to the community that's needed. The director of the adult day services, Heather Filanow, works very closely with Dale and is helping to work on and write and think about those guidelines to ensure that we will be safe and what is needed when a reopening is able to happen. At this point, we don't know when we will be reopening. We don't have insight at this point when those guidelines will be finished and what they're going to ultimately look like. We continue to talk about it as a senior leadership group and keep a very close eye because we do understand how impactful adult day programs are for our community.
Thank you. We have a question that I'd like to ask Jen to answer. It really is directed to Jen. Wondering, Jen, when you began seeing patients in the home, have you felt safe yourself as a caregiver?
Yeah, I've felt pretty safe the entire time. There hasn't been a time that I have felt uncomfortable going into a home. We have, all the PPE that we need to keep us safe in the home. There's never been a time that I've been without equipment that I need. We also have a great system of support within our management and our education department. If we ever had a concern or question, or trying to navigate tricky situation with a client, we can make a quick phone call or an email to get an answer. And as always, I found it very helpful to collaborate with my coworkers, especially those who were going in to see COVID positive clients. We found, what are you doing, to set up your car? What are you doing, to do this in a visit, what's worked, what hasn't, and being able to collaborate on that to tweak changes and do something different within our visits or, to prepare for visits. And I found that very helpful. So I've, felt completely safe going into homes and doing visits.
Great, thank you, Jen. And now we have a question. This is probably our last one. We're almost at 11. But as you all know, we serve a very diverse population, and that also includes family and children's services. And so, Todd, this question would go to you. Has anything changed with family and children's services during COVID?
Yeah, so we actually were directed by the state to go completely virtually. And so again, with some of those disadvantaged families, it wasn't an option to do Zoom visits. Some of them were familiar with it, but some of it had to be done through phone contact. That has been changing slowly. The new recommendation is to assess risk to the families, disengagement, lack of resources, and put those at the highest priority to be considered for an in-person visit. So in-person visits are starting to begin again. There is a risk assessment tool that's been provided by the state to the programs so that they can be very thoughtful about who rises to the top of level of need. And so we are making that transition currently and making sure that we're getting to those moderate high needs families in person to help them connect and be supported.
Yep, great. Thank you very much, Todd. So we are at just about 11 o'clock, and I promised a 1-hour meeting, so I'll stick to that. So I just want to say again, thank you so much. The audience here today, you attendees are our donors, our supporters, the people who believe in the work we do, and I just cannot thank you enough for supporting us, particularly during this pandemic. It's just been so heartening to know that while all of our staff are out there working to serve the community, that you're supporting us in doing all of that. So thanks very much. I'm so glad that you tuned in to this channel this morning, and I hope to see you soon.